Hi, I'm Greg Ginsberg, and I'm Professor of Medicine at the University of Pennsylvania Perelman School of Medicine and Director of Endoscopic Services at Penn Medicine and the Abramson Cancer Center here at Penn. I'm really pleased to provide this audio interview on our paper that's being published in Gastrointestinal Endoscopy entitled Long-Term Outcomes of Patients with Barrett's Esophagus and High-Grade Dysplasia or Early Cancer treated with endoluminal therapies with intention to complete eradication. My co-authors on this paper include Carlos Warner Argente, who was a visiting fellow from Barcelona. He's returned to Barcelona as a clinician and therapeutic endoscopist there. Tom Bonacristiano, who was a research fellow, who is a pre-med student at LaSalle University here in Philadelphia. Emma Firth, who's one of our expert pathologists and loyal collaborator, and Gary Falk, who is my colleague here and a collaborator as well. This work took place here at the hospital of the University of Pennsylvania. The vast majority of this was outpatient activity. For me, this has been the culmination of a great part of my life's work. This data set has been accrued over the past 15 years, and this has been our spearheading in clinical care delivery and clinical research as it pertains to patients with highly dysplastic Barrett's esophagus. The strengths of this paper are that it is a large and meticulously followed data set, and we have real long-term follow-up. Our intent was to be able to meaningfully compare results of endoluminal eradication therapy with those of operative resection. And in as most surgical series look at a 5-year follow-up, we've sat on this, allowing the mean and median follow-up data to mature sufficiently. The key takeaway points from our study are that it reinforces that endoscopic eradication therapy is successful in the vast majority of patients, and it yields durable results. Importantly also is that the results in terms of outcomes were similar between patients who entered with high-grade dysplasia and those that entered with intramucosal carcinoma. That hasn't been described in other series as yet. We come to recognize that successful effective therapy does require persistence and perseverance on the part of the physician, and to some degree components of creativity, and really embracing the concept of multimodal endoluminal therapy. So it's important that the treating physician has a number of different tools and familiarity with those tools in their endoscopic toolkit. It also reinforces the importance of achieving complete eradication of all intestinal metaplasia when feasible, because clearly the likelihood of recurrence of dysplasia was highest in that subset in whom we were not able to achieve complete eradication of all intestinal metaplasia. And lastly, our results reinforce the importance of long-term follow-up and meticulous follow-up. We've also come to recognize that there are subsets of patients that are refractory or have relative refractoriness to endoscopic eradication therapy. And some of our observations include patients that have very large hiatal hernias and simply those in whom we're unable to achieve effective prevention of ongoing reflux, be it acid or acid-suppressed reflux. Another important observation is that when recurrent intestinal metaplasia or dysplasia is identified, it's almost always just at the glandular side of the neo-squamo-columnar junction. And so I think an important recommendation for those of you who will be taking on this type of eradication therapy is to meticulously inspect visually, but equally importantly to take directed and random biopsies from 4 quadrants on the glandular side of the neo-squamo-columnar junction. This is really the hot zone, and we've identified patients who've had recurrence of dysplasia really in gastric cardio-oxyntic mucosa without even the presence of recurrent intestinal metaplasia. So this is really key, and the important aspect is that you almost have to have a contract with your patients to ensure that they're going to return for annual surveillance follow-up. We only observed advanced lesions in patients who failed to return as scheduled for their follow-up exams. And the other important thing is that if you identify dysplasia on surveillance, in almost all circumstances, this can be eradicated with further applications of endoscopic therapy. As this study enrolled patients over a decade and a half, it employed evolving techniques and technologies, and so some of these have been relegated to the endoscopy scrap heap, like photodynamic therapy, particularly in this regard. But clearly our evolution in utilization of endoscopic resection therapy evolved, and at this time we're currently embracing multi-mode endoluminal eradication therapy with upfront wide area endoluminal resection, and we do this when we are able to focally identify intramucosal carcinoma or nodular high-grade dysplasia. We routinely will resect up to 50% of the luminal circumference, more if necessary given the circumstances, and then we complete the eradication using radiofrequency ablation. And we feel that these results are achieving equal or superior eradication rates with equal durability and with lower adverse event rates. And so we're tracking this, and we're currently teaming with other institutions in an NCI funded protocol to track outcomes and to uncover molecular markers to predict biologic behavior in patients with highly dysplastic Barrett's and their response to therapies. So I hope you'll enjoy reading this paper, and I hope that it will enable you to alter your practice for the betterment of your patient population. Thank you.